you talked about us as physicians, being paternalistic to our patients. Do you think us as a community have been paternalistic to our physicians? Because the complexity in these
Mm.
guidelines really, I think, put fear into our clinicians as to if they were doing something wrong, right? I'm treating a patient
Yeah.
who couldn't be treated. And I feel like we're moving, hopefully very slowly, but hopefully away from that, where we're more trying to empower clinicians to treat as
Yeah.
opposed to tell them and restrict them from treating. What are your thoughts on that?
Yeah. Wow, that is such a powerful view, Kim, and I think, like, I've never heard it said that way, but I do feel like the restrictiveness is something that, has been concerning, and when you hear from patients, like, patients that are really kind of, activated, they often are pleading with us, like, "Why are you making it so difficult?" Like, if the something works and it's cheap and, like, the question is, you treat it as if it's harmful to us, right? You hold it back from us, like, "Oh, no, I can only give it to you if you make meet this and this criteria, and then what happens if I don't and I start the medication," right? And I think we haven't had a good answer for people, right? I think we say, "Oh, but then you're on medicine for the rest of your life, and you might flare if you go off," and for patients, that's not convincing, right? Like, that's an issue that's not a real issue about, like, whether that medicine is harmful for me to start earlier, right? Which I think is the crux, and for me as a patient, I had that very same question when I was deciding to start there because I didn't meet the, criteria strictly either, and I remember going around asking different specialists, and I remember thinking, "Oh, I put them in a really uncomfortable spot," like, they're really getting squirmy when I ask them this question. But then when I hear people say and, they say, "Well, if I was a patient, I would start treatment." Then it's like, "Whoa, like, you think that, why would you make it hard for a patient to have that exact same option?" And I think there's things that we know about Hep B now that are not reflected in our guidelines that, just because the way we do guidelines, right? So we know about integrated DNA, we know about the mutations, we know about T cell exhaustion, but those things do not get factored into our guidelines just because the way we do guidelines, right? We look for interventions and outcomes, on patients, but we're not looking on the micro level virology. But hearing all that, I think for a lot of I mean, when I talk to a lot of educated patients, they often are like, "Oh, yeah," and they choose treatment, right? Because they've heard enough of all the great science that happens at AASLD and other meetings. And I feel like we gotta listen to them. Like, if that's concerning to people, then, for our patients that don't have access to that, like, they should also be allowed to, access treatment. And, Kim, I think you're exactly right. There was actually a podcast, um, this Curbsider podcast, which some of you may have heard of before. These are like the smartest internal medicine doctors out there. And they interviewed Arthur Kim, who was on the guideline committee too. And they talk about Hep B and at the end of it, they were like, "That's great, Arthur. We're going to send you all our Hep B patients. This is like too much for us." And I was like, "No, that's not the message. Like, we're trying to make it so that, I mean, you guys are smart and you treat the most complex internal medicine." I mean, internal medicine is complex. As a primary care physician, I manage diabetes, I manage heart failure, hypertension, I manage like a lot of interactions. And so for us to say, that a primary care doctor cannot manage Hep B, which is only 3 oral medications, very limited doses, very little side effects, very little interaction with other medications. Doesn't make sense to me when I'm managing diabetes with like 20 medications, injections and orals and lots of side effects. And I don't feel that like fear, like you're saying, like, "Oh, I might be doing the wrong thing." Right. And I hear that a lot, right? People don't want to be thought of as doing the wrong thing for
Right.
patients. And so how do we change that, Kim? I think it's really interesting that that we have been paternalistic to the treating community, right? How do we get that out so people don't look at the really complex diagram and say, "Oh, no, this is too much for me." Like, "Oh, that patient didn't hit the 2,000, 20,000 mark, and therefore, you're not allowed to take medication."
Right.